Olá, boa tarde. Aqui é Bruno Trindade e a gente está falando ao vivo, direto da cidade maravilhosa, no Congresso da Brascrs 2024. Esse ano nós teremos um formato diferente. Nós teremos alguns palestrantes importantes aqui do Congresso, com os quais a gente vai bater um papo aqui durante algum tempo e discutir não só as aulas deles, mas talvez ir um pouco mais a fundo com as ideias e as novidades que eles têm trazido para esse Congresso. O Congresso eu acho que está maravilhoso aqui, tem muita gente, né? Vários palestrantes nacionais, internacionais, o público eu acho que está todo muito bem impressionado aqui. E para começar, nós temos aqui um time muito relevante, 2 Pinedas, né? Quanto que a gente consegue reunir na mesma mesa 2 Pinedas? We have Roberto Pineda from Boston, and we have Ángel Pineda from Venezuela. Muchas gracias. Thank you very much for stopping by and having this chat. It's an honor to have both of you here with us in Brazil. Thank you.
Thank you very much, Bruno. It's always wonderful to attend the Brascrs meeting. My first meeting was in 2010, so it's nice to.
Well, I've told you this, but I think you already deserve a Brazilian passport.
I'm working on it.
Yeah, you're entitled to a Brazilian passport by now because it's been how many meetings in Brazil?
I think this is close to my 20th visit to Brazil. I've been to most Brascrs meetings with the exception of 1 or 2.
I think you're a very dear friend from the entire Brazilian community and the society, and thanks for coming once again.
Thank you, my pleasure.
Yeah. And Ángel, você, eu acho que a gente pode falar em português, né? Nós temos aí o público que às vezes pode não falar no inglês, mas é um prazer também te receber aqui. É uma honra também. Você é prata da casa, quase,
sim,
né?
Sim.
Tem o histórico no Brasil.
Sim, muito obrigado pelo convite. É um prazer para mim ficar aqui no Rio de Janeiro. E sim, eu sempre venho para o Brasil. Aí faz muitos anos eu estudei na Escola Paulista de Medicina. E é por isso que eu falo mais ou menos português.
Muito bem. So I'll start with Roberto. Roberto, we were just talking on your wonderful lecture you gave this morning on the challenges of small pupil. We all know you're an expert surgeon and you're able to do amazing things inside the eye. But what's the main challenge you find on these patients?
So Bruno, I mean, I think we're all stressed when we do small pupils because many things can happen. And I think that the way to make it less stressful is to, understand the principles behind small pupils and also learn how to use the tools for the small pupil. I obviously we have hooks and rings now that are very useful. And there's many different types, and I think it's good to get comfortable with a few different types of these devices, depending on where you are and what's available. And one area that I think kind of a variation of the small pupil is IFIS, or intraoperative floppy iris syndrome. So, which
gives an additional challenge, right? It's not only the small pupil, right? But the iris itself.
Correct. So you have this already small pupil, and then you have this disobedient iris that does not follow the rules. Yes. So it makes many steps of the procedure very, very, very challenging.
Yeah, and you were saying that, well, probably the first time you notice that it's an IFIS case is when you start to hydrodissect, right?
Right. So I think most of us will first see the iris want to go outside when we're doing the hydrodissection. And I think that, I myself had not come up with a good way to control that. But at the ASCRS meeting in Boston, there was actually a video by an Indian ophthalmologist that showed a very, very nice way to manage that. And I think it's the most clever idea I've seen. And it was really to remove the sleeve, the silicone sleeve from the phaco handpiece, which we all have if we're doing phacoemulsification. And we thread the cannula right through the center of the sleeve. And then you place that sleeve with the cannula in the main wound. And basically it prevents the iris from prolapsing. And it also allows for the egress of fluid through the center of the sleeve. And you can go about and do your regular hydrodissection without having to worry about iris prolapse. Then it also equalizes the pressure gradient. So when you take it out, the iris doesn't follow.
That's interesting. But how would you choose? Because, I mean, you can have some sort of feeling that it is a knife's case, but sometimes you get surprised, right?
Right.
How would you choose the case to use this strategy, or would you use it in everyone or any small pupil?
Yeah, I mean, I think, obviously if you knew you had problems in the other eye, you would use it on the second eye. I mean, that's probably the most obvious time. But, sometimes, any small pupil that doesn't dilate well, anyone who has a history of using tamsulosin or some similar medication, you might be worried about having such a similar situation. But yeah, you're right. Sometimes it's not until you're actually doing the phacoemulsification and the pupils coming down. But I think in this case where I used it, I just barely touched the wound and the iris started to peak a little bit. And I knew that it probably was going to prolapse if I didn't do that. So,
I mean, by the time you get to hydrodissect, you've already completed the capsulorhexis, right?
Correct.
So you've already managed at least some part of a small pupil. Would you think that this strategy is still valid if you are using a pupil expanding device like Manukin ring or the
Yeah, so I mean, I think rings and hooks don't guarantee you won't get iris prolapse. I think my if I know someone has a very floppy iris, I do prefer hooks over rings just because I can customize it a little more. And I can do a sub-incisional hook if I need to. But again, I think anytime you're suspicious, I mean, it takes just a minute to do this. I mean, we don't, so anytime you're suspicious of maybe a case that might be iris prolapse, you can do that prophylactically, just as a precaution. But I just thought it was like a very original way to do something that you already have available to you. You don't have to open up more supplies or anything else. You're going to just put it right back on your phaco sleeve. Yeah, it takes a few seconds, but we all know that once the iris comes out once, it's going to want to come out again and again and again and again. And preventing that first prolapse, I think, is really important.
And Angel, I think that on the other hand, when you don't have a master of a surgeon like you guys, like Roberto, in these cases, they might end up with some sort of complications. And this patient might be left aphakic, right?
Yes.
And then it'll come to you. And then you'll have to deal with the aphakia left at a second surgery, right?
Yes.
And we all know how expert and your experience on secondary IOL fixation. What's your, and there's so many different techniques at the moment,
Yes.
right? And what's your go-to technique currently for these
Yes.
sort of patients?
I have been working with scleral fixation techniques since many years ago. And I began using the scleral fixation techniques with Prolin 10-0. Then some years ago, I moved to the glue IO technique that was developed by Agarwal. And then I began working in a hospital setting in Venezuela. So we have the limitation that we have only one kind of intraocular lens. There is a single piece acrylic foldable intraocular lens. And we didn't have the way to fixate those intraocular lenses. Hydrophilic intraocular lens. So I was thinking how to resolve that problem. And I discovered the Gore-Tex suture. And then I decided to pass the needle of the Gore-Tex suture through the intraocular lens, doing the transfixation. And that's how I developed the technique. And the main advantage of this technique is that it is possible to fixate any kind of foldable intraocular lens, no matter the design of the haptics, no matter if it is a hydrophobic, hydrophilic, one piece or three piece. So it is possible to fixate any foldable intraocular lens with that technique.
And do you knot the Gore-Tex around the haptic, or how do you do
No,
it?
no. I as I told you, I do the transfixation of the optical zone, okay, of the optical part of the IO.
Okay.
I mark 4 points far away from the visual axis, and I pass the suture through the 4 points.
So you forget the haptic.
Yes, I forget the
You leave the
haptics.
haptic alone.
Yes.
Right. And I imagine, can you cut the haptic, or you don't bother to cut it?
I would cut the haptic, but most of the time I leave them.
as it is.
Yes.
And I would imagine that this is probably challenging to center the lens.
The
So
center-
what are the pearls there?
The center is very easy because you have at the middle of the suture, you have 2 extremes of the suture in the nasal part of the eye, and the other set of the suture in the temporal side of the eye, and then you adjust each pair of sutures, and you can perform the centration of the IOL very easy. And then when the IOL is well centered, you do the knot, okay? And you bury I like to bury the knots inside one of the sclerotomies, okay? For avoiding the erosion of the conjunctiva, okay?
And have you ever had any sort of IOL opacification after this sort of procedure?
No, I haven't had IOL opacification. I have used hydrophilic and hydrophobic IOLs, and I haven't had opacification of the IOL.
Right.
Because the opacification of the hydrophilic IOL are related to the use of gas or air bubble in some procedures. So.
Roberto, I remember when I trained under you many years ago.
Yes.
And I remember when I was there, you were performing glued IOL. Right?
Yes.
What's your preference at this moment?
I mean, I'm pretty much still. I mean, I use that sometimes, like in an open sky setting, when it's really hard to do just a standard intrascleral haptic fixation. So it's a technique that I occasionally use, but pretty much I'm doing intrascleral haptic fixation with usually like a 3-piece IOL, usually like the CT Lucia or the Johnson & Johnson AR40M, AR40E. Those are kind of the 2 lenses I use most commonly. I do occasionally still do scleral fixation as well.
PMMA lens.
With PMMA lens, I use 9.0 Proline. Rarely I'll use Gore-Tex, but they all work. And I mean, I've lived through enough iris fixation. I mean, every kind of fixation technique, and I do think scleral fixation of some kind is probably the long-term winner in all of this.
And how do you find the differences between the PMMA haptic and the VDL
Oh yeah, so I mean, I think the PVDF material, I think it flanges a little bit larger and easier, and of course the haptics are much more flexible. Now the haptic optic junction has been called in question, and I think people think they can do yes, and people think they can do anything with the haptic, but you have to be gentle with all of these techniques, otherwise you can damage the optic and haptic.
Angel, do you think that the Vortex is superior than the polypropylene traditional suturing for technique like yours?
Yes.
Because it's far thicker, right?
Yes.
To pass it through the
you can find two Gore-Tex, the CV6 that are used for cardiovascular surgery, and the CV8 that is used for ophthalmology surgery. So we use the CV8, and the thickness of the suture is equivalent to 7.0, but the suture is very elastic. It's very easy to manipulate under the microscope. The white color make it easier to see. And the only thing is that it's not approved for intraocular use by the FDA, but that is not a problem in our Latin American countries, especially in Venezuela. And the other thing is the cost. It's more expensive than the Prolene.
And do you think that this technique can be used with a toric implant, maybe? Have you used any toric implant?
I haven't done. I don't know if I could do it.
You think it's possible?
Yes, I think that. Yes, I think that it's possible, but I haven't done, because most of the patients that are affected are complicated patients. It's a second surgery, so I like to do the more simple things. So doing a fixation.
Keep it as simple as possible.
Yes.
Nós tivemos aqui a entrada do Gustavo, aqui, que é um expert também nesse assunto. Puxa a cadeira aqui, Gustavo. Tudo bem? Nós estamos falando aqui, Gustavo, a respeito de fixação escleral dos pacientes afásicos. E o Angel estava comentando aqui a respeito da técnica dele. Fala um pouquinho da sua técnica de preferência atual.
Yeah, money is, I think English is better. Yeah, money is, for me is better, but that session that you are presented a case, an amazing case, was a lot of cases about the fixation.
Yeah.
But yeah, money I think is the number one now today.
Your hands, it works best.
Yes.
And I don't want to keep this much longer, but because I know how busy you guys are. But let me just ask you a specific question, because I remember a couple of years ago I asked you about your current practice on drops. And I believe you told me you're going dropless, right?
Yes.
You've gone dropless.
I've gone dropless. So for the most part, for routine cases, patients that don't have any history of glaucoma and such, we basically we inject Vigamox 0.1 into the intercamerally, and then we place about 0.05 in and hydrate the stroma of the main wound to allow it to kind of leach into the eye. And then we give 4 to 8 milligrams of triamcinolone subconj. So when we do the subconj, I mean subconj. I don't mean under tenons.
Right.
Because if you do need to excise the deposit of the triamcinolone, it's much easier if it's not under tenons. So
where in the eye?
So it does matter. Thank you for reminding me about that. But we usually give it infra nasally because it's cosmetically, it hides the deposit, which can last potentially up to 2 months. So of course, if you have a big white spot on the surface of the eye, it can be kind of noticeable, but usually you have to pull down the lid in order to be able to see the deposit. But I would say it works very well. Patients are thrilled that they don't have to take drops. It's actually a status symbol for them, because they say, my friends are all asking where my drops are. I'm like, I don't need drops. No drops at all. So in general, I mean, I think for, the vast majority of patients, they've all done very well with that. Occasional breakthroughs, where we restart drops if need be. A rare patient that has enough of a steroid response, we usually just put them on some glaucoma medications for a month. But most patients have done fabulous.
How do you do normally with routine patients? Do you do any sort of
No.
intracamerals that
I always use moxifloxacin intracameral at the end of the surgery, and then drops of antibiotics and dexamethasone for 3 weeks. The classic, treatment after cataract
but
surgery.
with drops? You keep patients drops, on drops.
Oh, what?
They have to put drops.
Yes,
Really,
yes.
Right?
They have to put drops.
Yeah, no, of course, with drops, but we start with the no steroid anti-inflammatory 4 hours before, okay, to push down the macular edema chance, and then so also like our friend here from Venezuela, so also every time intracameral antibiotic and morphoxacin and dexamethasone in the post-operatorium, and I put drops and push dexamethasone about 3 or 4 weeks, going down slowly. Okay. Yes, and antibiotic is 1 week. Is this?
So you're the only dropless surgeon in this thing. Amazing.
And about the IOP.
Well, no, we did do a study. We looked at about 350 of our patients. And, we did have, this was early on when I was injecting closer to like 16 to 20 milligrams of triamcinolone. We did have 2 patients that had very high pressures where I needed to excise the triamcinolone. And 1 patient did need a trap, actually. So that was early on. Yeah, 4 to 8. I've not had any problems with that. So it's like 1 to 2. We usually take 40 milligram per ml bottle, and we just inject 0.1 to 0.2. Now, I've not had any issues since I've used that level, which has now been probably close to 2 years.
And you?
Well, I normally do drops. I don't go dropless. Same moxifloxacin, dexamethasone. Although I don't like to inject moxifloxacin in the HC, but I'm obsessive compulsive in checking for any leakage at the end of surgery. So I'm very cautious for any potential leak, and I like to suture the incision in any case that I think that the incision is not secure. So that's what I do. But
The eye drops, they use it together, so in the same drops, the antibiotic, or use to separate
down
like me.
over 3 months.
And Bruno, that's what I would say. If the case isn't routine, if I'm putting in a suture, they get drops.
Right.
So it's really for the most routine, the most vanilla
Right.
cases where we do dropless. But it's well over 50%.
Right.
So
It's amazing. I think it's such a paradigm shift. I think it's more of a paradigm shift that the surgeons need to get used to this.
Yes.
Rather than the
I think the publications are there and to support that.
Evidence to support what we use.
Yeah.
But I think surgeons, especially surgeons from Minas Gerais, which is where I come from, are very suspicious of anything. So we tend to be very conservative of change.
Yes.
That's why I'm still old school. Dropping.
Yes.
Put a drop in the eye.
Okay.
All right, guys, but
Thank you.
I think it was amazing to have you here. I think this was a great talk. I thank you very much, Roberto, Angel, and Gustavo,
Thank
for
you,
stopping
Bruno.
by.
Thank you.
Ao pessoal, fiquem ligados que nós teremos agora várias outras mesas redondas como essa ao longo de todo o congresso. E eu espero que vocês tenham aproveitado e a gente se vê em breve. Muito obrigado, até a próxima.
Ciao.
Thank you, guys.